Hi friends, in today's class we will discuss pigmentary glaucoma, which is also called pigment dispersion syndrome, and the clinical signs of pigmentary glaucoma in the cornea, iris and on gonioscopy. So the mechanism of pigment dispersion, that is reverse pupillary block, the mechanism of Iop rise and the management works. Okay, so let's begin. So pigmentary glaucoma is unusually heavy dispersion of pigment with increased outflow resistance leading to glaucoma. So if there is only pigment but no glaucoma, it is called pigment dispersion syndrome. So the clinical features, it is more common in young myopic males in the third decade. So male to female ratio is around 2:1. Coming to the mechanism of pigment dispersion, we have some hypothesis. So there is Scheie and Fleischer. They said it is due to degeneration of iris pigment epithelium. Then there is another theory, that is elongated anterior zonules which are pigmented, which are encroaching the central visual axis. Then we have mechanical theory of Campbell. So this is based on reverse pupillary block. So what does this say? So there is a backward bowing of peripheral iris which leads to mechanical rubbing of zonules against the iris pigment epithelium. Backward bowing of iris leading to mechanical rubbing of zonules against iris pigment epithelium. So just to explain it better, we take it as a cornea. This is the lens. So this is normal side. So we have zonules and the iris, and here is the Schlemm's canal. This is a cornea. Right. So here there is production. So these are our zonules. Right. So the aqueous, it can flow from here and then it will go into the AC and then exit. So this is normal. So here what happens, there is reverse pupillary block. So there is a iris which is touching the lens near pupil. So this iris is a little bit of concave configuration, we can say, and so what's happening here, there is something called one valve effect. So the aqueous which is being produced, it will slowly go into the anterior chamber, but it cannot exit over here. Right? So this is the mechanism. Now coming to mechanism of Iop rise. This is the mechanism of pigment dispersion. Understood? So because of this backward moving of iris, there is rubbing of these zonules against the iris pigment epithelium. Understood, right? So here they are getting rubbed. So here is the mechanism of Iop rise. So what is happening now? So there is pigment is released. This pigment, the trabecular meshwork cells engulf the melanin. There is phagocytic overload. And partially digested melanoprotein is retained inside the inside the cells, and this causes oxygen free radicals. So these free radicals, they cause trabecular meshwork cell death and injury. So the collagen is getting exposed. It then fuses, obliterates the outflow channels. There is increased resistance to outflow, leading to pigmentary glaucoma. Right? So this is the mechanism of Iop rise. So now coming to the signs. In the cornea we can find Krukenberg, spindles. So what are they? They are pigment accumulation on the posterior surface of central cornea in a vertical spindle shaped pattern. So why are this formed? This shape especially and all are because of the aqueous convection currents, which are then phagocytosed by the endothelium. These are not pathognomic. Okay, now coming to iris. In the iris there is mid-peripheral, radial, spoke-like pattern of transillumination defects, and pigment granules and are found at the stroma of iris, uh, at the zonules, and also this is called zentmayer ring or shearing. Coming to gonioscopy. So there is dense homogeneous band of dark brown pigment around the circumference of the trabecular meshwork, and there are more iris processes which are inserting anterior to the scleral spur. On fundus examination, we have to remember there is more chance of retinal detachment. That's why we have to perform a fundus examination in these cases. Now coming to the management pulse. It has been found that these patients, when they are doing activity like exercise or anytime, there has been increased pigment release, right? So after exercise there is more pigment release. So that's why IOP is to be measured before and after. So if there is a significant pressure rise, then we have to use pilocarpine drops to prevent this rise of the exercise, right? Okay, so coming to the medical management. So medical management includes myotic therapy, but with myopic, so what does this myopic therapy do? It will eliminate the contact between peripheral iris and the lens zonules. So it will eliminate the contact between the iris periphery and the zonules, which is causing the pigment release, right? So that's why myotic therapy is used, but there is increased risk of retinal detachment in these cases, and already they are myopic people, and this pilocarpine, it will be not be tolerated by these young myope because it causes further myopia, right? So pilocarpine is one of the drug. Then we have alpha blocker, alpha agonist blocker, that is thymoxamine and dapiprozole. Thymoxamine is not available worldwide. It causes meiosis without the cyclotropia, whereas dapiprozole is available worldwide. Then we can also do carbonic anhydrase inhibitors and all those. And coming to the surgical therapy, we have to perform laser peripheral iridotomy in these cases, so which relieves the posterior iris bowing, causing easy flow of aqueous over and below. We can also perform argon laser trabeculoplasty or selective laser trabeculoplasty and filtering surgeries. We'll go into the details of these surgeries in a separate class, but here we'll just discuss what is important related to this specific topic, right? Okay, so that's all regarding the pigmentary glaucoma. Thank you.